So Kanti Children's Hospital is the only government children's hospital that is catering to children under 14 years of age all over the country, from all over the country. All the cases referred to Kanti Children's Hospital. This is a tertiary care hospital, and these cases are referred for tertiary care to Kanti Children's Hospital. Among the different departments at Kanti Children's Hospital, the oncology department, the department of hematology, pediatric hematology oncology, caters to children with hematological problems and different cancers. So at present we are in the cancer ward where we provide chemotherapy to children with different cancers, and these cancers range from acute leukemia to brain tumors. Acute leukemia means acute lymphoblastic leukemia, acute myeloblastic leukemia, bone and soft tissue tumors like rhabdomyosarcoma, pediatric rhabdomyosarcoma, pediatric osteosarcoma, pediatric Ewing sarcoma, pediatric liver tumors, pediatric renal tumors, pediatric tumors with different brain tumors. Okay, that would be medulloblastomas, low-grade gliomas, germ cell tumors, extracranial and intracranial germ cell tumors. Unfortunately, we do not have a bone marrow transplantation unit, so patients who need to have a bone marrow transplantation will need to be referred to other centers. Bone marrow transplantation at present is not yet available in Nepal, but other institutes are trying to bring in bone marrow transplantation.
How many kits you provide?
We have 31 beds, out of which 26 beds are indoors, inpatients, and 5 beds are daycare center.
Okay. During the year, how many patients you serve?
In accordance with the patients, demographics of Nepal, there should be at least, Nepal has 30 million people, and 120 million per million have cancers. So that would mean approximately about 3,600 new cases of cancer should be there in the population. Unfortunately, these cases are not caught, so they come on a voluntary basis to our hospital. So, we provide about 300 to 400 new cases of cancers at Kanti Children's Hospital.
And how is the successful on this cancer, the mortality and the successful of curing?
I did my fellowship from the United States, the Children's Hospital Los Angeles, in preparation to provide, to treat children with different cancers. And I'm a member of the Children's Oncology Group. Most of our protocols are based on the Children's Oncology Group, but we do use other protocols from France, for example, for non-Hodgkin's lymphoma, and other countries. The best, in the best interest of the patient, we try to modify our treatment in accordance with our needs and in accordance with our resources. And our main constraint is that most of these patients have infections. These are immunocompromised patients right from the beginning, because they have different cancers, and because of that they have different infections, and many of these patients who die usually die because of infections.
Okay.
Another thing is, Nepal is a country where malnutrition is prevalent in the normal population. So most of these patients who come into the ward at Kanti Children's Hospital are already malnourished when they come. So their capability to tolerate chemotherapy and to fight against infections is very low. So they have tendency of more infections, and they die of infections. Okay. Another thing is, Kanti Children's Hospital, although it's a tertiary care hospital, does not have in-house blood bank services. So many of the time, one of the complications of chemotherapy and the cancer itself is that children have low hemoglobin, low platelet counts, low white cell counts, and when they need blood, sometimes the child starts bleeding, and when there is acute need for blood, the parents have to go to another place to find blood and then bring it and provide it to the child. Sometimes it happens that the child is bleeding, and while the parents try to find blood, the child dies. Okay. So it is very important for a tertiary care hospital like Kanti Children's Hospital to have in-house blood bank services. Okay, that is not there, but we are trying to develop collaborations with different other different institutions to provide in-house blood bank services.
Okay.
The third thing is, most of these patients are very poor. Nepalese, most of the per capita income of most Nepalese is about $700 a year. Okay, that's very low. and there is no insurance service in Nepal like in other countries. So most of the medicines have to be bought from the pockets of the patients themselves. Patients who are, whose parents are fighting to, feed their family, have to spend a large part of their money in trying to treat children with cancers. And that becomes very difficult for them. But we have been able to develop a fund at Kanti Children's Hospital with the help of different donors, and we have elective students coming into Kanti Hospital. They pay a certain amount, and 50% of that amount goes into the oncology fund. And we use that fund, the interest from that fund, to buy medicines for children with cancers, and we distribute it evenly. But even that is not enough. For example, to treat a child with high-risk acute lymphoblastic leukemia in the United States would be about $400,000. In Nepal, that is just unimaginable. Patients cannot pay that amount, but we have been able to cure patients with $10,000 to $15,000. And that is basically because we compromise on other things. You can see that the ward is not a very suitable place to treat children with cancers. It should be, sterile. We have to have, laminar flows, HEPA filters, so that the ward is almost sterile, so that the children infection rates are low. But we compromise with things like, nutritional supplements, for example, is not there. That way what happens is, many of these children are malnourished while they are on treatment, and they have a very difficult time going through the treatment. That's why, although the cost of the medicine is low, but the children will not be able to even buy those medicines, as well as supplement their nutrition and buy very expensive antibiotics. So insurance is another, we have to have either insurance, health insurance, or the government has to support these children with cancers, or we have to look for other public partners who will be able to support these children with cancers. And children's cancers are, one of the good things about children's cancers is more than 80% of the cancers in children are curable. Yes. They will be able to, curable. Actually. They will be able to be cured of the disease, and they can grow up to 50, 60, 70 years and become doctors, engineers, lawyers, or whatever they want to be, and be a part of the society and bring creative, be very creative and make positive inputs to the development of the society. And in order for us to bring that opportunity to all the children in Nepal, we have to actively go out into the public and seek children so that they can be caught in early stages, stage 1, stage 2, for example, so that their disease is curable. When they go on into stage 3, stage 4, it is very difficult to cure. Even in the United States, stage 4 disease is very difficult.
So it's a problem of information too. There's no information about cancer.
Exactly.
So your work will be cure the kids here, find for a support from different way, and at the same time organize a campaign of information, so that, what is a tumor, what is a cancer, how it's developed, how to recognize it.
How to recognize it and what the chances of cure are, and catch them early so that they can be brought to the hospital and provide chemotherapy. Most of these people, because they don't have money, they are so scared to come to the hospital because they don't want to spend the little money they have to treat a child with cancer and then have the rest of the family go hungry for the rest of their lives. Okay, we have had children who have been treated out here. The parents sell their house, their land, and try to cure their child. We cannot save everybody, and once the child dies, the whole family lands up in the street. They cannot move on further in life. Okay, so these are difficulties that we have. We do not have a pediatric radiotherapy unit out here. Certain children, although most cancers do not need radiotherapy, but certain cancers do need radiotherapy, and that is an important aspect of cancer. Surgery, the surgeons are general surgeons out here, general pediatric surgeons. We would like to have surgeons who are, trained in pediatric oncosurgery, so that, appropriate surgery is performed, so that, these children can have, for example, osteosarcoma, it's not necessary to amputate the leg. Okay, you can do a limb sparing surgery. Okay, you provide chemotherapy and then do a limb sparing surgery, and then later on you can provide a prosthesis, and the child will be almost, you will have a very good quality of life.
Okay.
Another aspect is the follow-up after treatment. When the children have completed chemotherapy, we have to have a good network to catch these children so that they come, on a regular basis for follow-up, so that we can catch them even if they do relapse or recur. We can catch them at early stages and provide, relapse therapy. And then we need to look into their quality of life. If they are receiving good education, good nutrition, their hormonal functions, physical, mental development is important.
Fantastic. Okay.